Okay, hello everybody. This is going to be our lecture on high-risk pregnancy, and I am going to talk about hyperemesis gravidarum and diabetes during pregnancy. Okay, let's see if I can get the slides to move. Okay, there we go. Here are the objectives for the lecture. And so first of all, we're going to talk about hyperemesis gravidarum. You may hear it referred to as just hyperemesis when you are out on the units. Now, yes, a woman does experience increased nausea and vomiting during the first trimester of the pregnancy. That is completely normal, related to the hormones of pregnancy. This is something a little different. Hyperemesis is when a woman continues to have excessive nausea and vomiting during her pregnancy. And the nausea and vomiting is excessive to the point that it starts to cause a weight loss. We know that women are supposed to gain weight during pregnancy, so they start to lose weight because it affects their nutritional status. It also affects their electrolyte balances, and they will see shifts or abnormalities when we draw electrolyte levels. And then all of this just creates a nutritional deficiency, not only for the woman's health, but also don't forget that we have two patients during the pregnancy, and so it can impact the nutritional status of the developing fetus during the pregnancy. And hyperemesis can continue throughout the entire pregnancy. 80% of normal morning sickness will end at 12 weeks or that first trimester. Okay, what causes hyperemesis? We're not really sure. It can be a combination or one of these listed etiologies. It can be related to stress, it can be related to the hormones of pregnancy, or maybe other coexisting medical conditions that a woman might have. And then it also sometimes can be somewhat of a psychosocial or psychological manifestation related to the circumstances of the pregnancy, which then can also cause stress, which then some think can be a cause of hyperemesis. So symptoms that we will see during hyperemesis is that the woman has excessive vomiting. Now the vomiting is to the point where they can't hold down anything. They may not even be able to hold down water. So it's to the point that they really are vomiting anything that they attempt to take in, which then is going to lead to a weight loss during this pregnancy. It also can cause dehydration. Now remember, how do we assess dehydration? How do we know that a person is dehydrated? We are going to assess their mucous membranes. So their mucous membranes may be dry. Also, we want to assess skin turgor. They will have poor skin turgor. So remember, when we assess skin turgor, we are looking for that tenting. So you can take either the top of their hand or the skin on their upper chest, and you just want to pinch it. And if they have good skin turgor, it will bounce back. If they are dehydrated, then the skin will stay tented. We may see slight changes in blood pressure and pulse, just related to decreased volume. Okay, and then as I mentioned before, they will assess electrolyte levels, and we will see changes in electrolyte levels, maybe sodium, potassium, all of those electrolytes that are related to our intake and output and our nutrition. So when a woman comes in, maybe complaining of excessive nausea and vomiting, we really need to be able to differentiate what is going on. Is this just normal nausea and vomiting? Is she within the first 12 weeks of that pregnancy and it's normal morning sickness? Is it hyperemesis, or could it be related to some other condition going on? Because nausea and vomiting can be manifestations of many clinical situations. So we want to get a very detailed history and physical. So we want to know everything about her nausea and vomiting episodes. How often is she vomiting? How much? The color, what is she vomiting? Is there anything that triggers the nausea and the vomiting episodes? Okay, is there anything that helps alleviate those episodes? Other GI issues we want to rule out. So is there any diarrhea, indigestion, abdominal pain that is also going on at the same time? Of course, weight, vital signs. We're going to do a complete head-to-toe physical exam. And then, of course, we're going to draw blood for labs, a CBC to get our standard baselines of those hemoglobin, hematocrit, platelets. Then we're also going to do a basic metabolic panel so that we can get electrolyte levels, see if they are being affected. And then remember that there can also be a psychosocial component to hyperemesis. So we want to sit down and we may have to ask some questions about her support systems, about the circumstances of the pregnancy. Is there any increased stress or anxiety related to the pregnancy? Okay. Alrighty, so initial treatment. Once the woman is diagnosed with hyperemesis, the initial treatment is focused on rehydration, reestablishment of those electrolyte levels. Okay, she will be admitted into the hospital for this initial treatment. Okay, so our main goal is to rehydrate her, get those electrolyte levels back into balance. So she will be put on IV fluids. There may be electrolytes added to those fluids, depending on her nutritional status. She may be put on total parenteral nutrition for a period of time, depending on how long this has been going on and how bad it has affected her nutritional state. We want to monitor INO, make sure that the kidneys are still working, they haven't been affected, what goes in is coming out. She will be NPO. We don't want her to eat anything during this initial period with that excessive nausea and vomiting, okay? And remember that while our patients are NPO, it's very important to perform frequent, adequate oral care because our mucous membranes can get very dried out, and if she's dehydrated, then that just kind of exacerbates that. She will be weighed daily while she is in the hospital. Now, things to remember that you should have learned during 203 and 210, if we're doing daily weights on our patients, they should be weighed at the same time each day. They should be weighed on the same scale. They should be wearing the same type and amount of clothing. Okay, so if they're in the hospital and they're wearing a patient gown, they should only be wearing a patient gown every time they are weighed. This is to make sure that we are getting accurate, recurring weight assessments. And depending on how severe the nausea is, then the woman may be put on anti-nausea medications. That is kind of different for each healthcare provider who would be managing her case. Now, once we get through that initial treatment phase and we have rehydrated her, her electrolyte levels are back in balance, she is going to go home. So we want to start introducing now food and have her start eating. So there is a diet called the hyperemesis diet. And this may sound familiar when we talked about nausea and vomiting during the prenatal period. Small, frequent meals. We want her to be eating small amounts frequently throughout the day so that she doesn't just dump a lot of food into her stomach. They do say that when you are nauseated, that if you drink your liquids separate from eating your food, that can help. So when she's eating any of her small frequent meals, she shouldn't be drinking at the same time. So she can either drink maybe 30 minutes before her meal or wait at least 30 minutes after her meal and then drink. It can be helpful to have a bedtime snack, maybe some type of carb snack that is bland to help her through the night. And then a bland diet may be what's best, so not to trigger that nausea. We do want to teach her about high protein foods. We talked about this before because she needs high protein for the development of that fetus. And then, of course, ginger has been proven to help with nausea, so maybe ginger ales, ginger teas can also be helpful. And rest. Women who are experiencing hyperemesis and have excessive nausea and vomiting sometimes have difficulty sleeping. Their sleep pattern can be disturbed. So we would want to encourage her to take rest periods throughout the day, maybe take a nap or two during the day. And then these would be some of the medications that might be ordered if her nausea and vomiting continues. She could go home on these medications. These might be used while she's in the hospital. Okay, so that was hyperemesis. So now we're going to talk about diabetes. And hopefully you have had diabetes in med-surg already. You know that there are two types of diabetes, type 1 or type 2, okay? And then we're also going to talk about gestational diabetes. So we're going to talk about pre-gestational diabetes. This is when a woman is pregnant and has already been diagnosed with either type of diabetes, okay? So she already had type 1 or she had type 2 diabetes and then she becomes pregnant. She sometimes is considered a high-risk pregnancy. She needs to be monitored a little closely. We know about it from the beginning of the pregnancy and we're already going to incorporate maybe certain changes in her prenatal care. Gestational diabetes is when you have a woman who is not diabetic, okay? And then during her pregnancy, she develops diabetes. That is gestational diabetes. So gestational diabetes is a form of diabetes or glucose intolerance that develops during the pregnancy, and it did not exist previously, okay? They can manifest in different levels or severities. Some women can control it with diet. Some women may have to take oral medications. Some women may have to go on insulin injections during the pregnancy for the gestational diabetes. Why we are concerned if a woman has diabetes during her pregnancy is because it does place the risk of herself and the infant at risk. Her health is at risk. If she already had diabetes, so if she was a pre-gestational diabetic and she does not control her sugars very well during the first trimester, it does place her at risk for a miscarriage, okay? That spontaneous abortion is the medical term for a miscarriage. It also can place her at risk for having a cesarean birth later, forceps, vacuum. We will talk about that later. You can just see here, this is a macrosomic baby, which is a baby greater than 8.5 pounds. This puts her at risk for a difficult delivery because the baby is so big. And so that's what puts her at risk for this complication. We know that people with diabetes are at risk for infections. There sometimes is a link between preeclampsia that we talked about and diabetes, ketoacidosis, and then of course episodes of hyper and hypoglycemia. Now for the infant, the risk is that if a woman does not manage her diabetes well during pregnancy, and she continues to have elevated levels of glucose, and maybe she's in a state of ketoacidosis, this can cause the baby to die in utero. A woman who is pre-diabetic or has pre-gestational diabetes and does not manage her sugars well during that first trimester. Remember those weeks 3 through 8 where the infant is at risk for injury related to maybe toxic, if it's, what am I trying to say? Is exposed to toxic substances. And we talked about how that can cause anomalies when the body systems are developing. Well, increased levels of glucose can also be considered toxic to the developing fetus during that period of time and can cause anomalies. One of the big things that we see with a woman who does not control her sugar very well during pregnancy is that her baby gets very big. A big baby is called macrosomia, and this is a baby 8.5 pounds or greater. And I have seen babies of diabetic women reach the weight of 10 pounds, 11 pounds, 12 pounds, even 13 or 14 pounds. So we're talking big babies. And when a baby gets that big, the delivery gets difficult. And so you can see here, this baby, look how broad that baby hair is across the shoulders. I refer to these as little football players. They're just very broad across the shoulders because they want to just barrel through that line on the football field. Well, these shoulders and this large head make it difficult for the baby to maneuver through the birth canal sometimes. And it can cause injury to the infant's clavicle. Sometimes they even break. It can cause cephalohematoma if a vacuum extraction is used, and facial nerve injury if forceps have to be used because the baby is so big and having difficulty during a vaginal birth. Okay, so what we are going to talk about here is during a just typical, normal, expected pregnancy, there are changes in insulin needs that happen to every woman. Okay, so this is the normal that happens during a pregnancy. So during the first trimester, a woman does not need as much insulin. Okay, now if she's not diabetic, then her body will adjust and not make as much insulin. Or if she's pre-diabetic or pre-gestational diabetic and she's on insulin, she may have to adjust her insulin levels to not take as much because the body doesn't need as much insulin. Whoops, I didn't mean to do that. Because the nausea and vomiting of the first trimester, she may not be taking in as much glucose because she's not eating as much. She does not need as much insulin during the first trimester because some of her glucose is starting to go to the developing fetus. Okay, so she doesn't have as much glucose circulating in her body system, so she doesn't need as much insulin. And so you can see here why. Also, the pancreas the pancreas during pregnancy starts to increase its production. And so this then leads to hypoglycemia during the first trimester. Because this occurs just because of different hormones that are excreted during pregnancy. So then we have to make sure that we teach our woman signs of hypoglycemia. Okay? I hope that makes sense. Okay. Now, during the second trimester, a woman is going to need more insulin, okay? Because there are these hormones, HPL, which is secreted by the placenta, estrogen and progesterone, which are also secreted some by the placenta and others we just already have. It's part of our female system. They work as insulin antagonists. So what they do is they just make the insulin that we already have, it doesn't work as well. Okay, it's that simple. It makes our insulin less effective. And so if our insulin that we already have is less effective, then, and if we have increased levels of glucose, we may need more insulin. The other thing that occurs, and you can highlight this, red flag it, is this diabetogenic effect. Now, this occurs on purpose. The body does this to protect the infant and provide glucose for the infant. This insulin resistance that occurs here happens so that our body does not use up all of the glucose circulating, and there is leftover glucose to travel through the placenta to the fetus, so the fetus has a glucose supply, because the baby gets his or her glucose from the mother. Okay? So, just to clarify, these hormones create an insulin, they work as insulin antagonists. So they just make my insulin that I have less effective. By making my insulin less effective, I don't use up all of the glucose in my body. That leaves glucose available to travel through the placenta to the fetus, because the fetus needs glucose to grow. And the fetus gets his or her glucose from the mother. Okay? It's that simple. You don't have to try to overcomplicate it. All right. During the third trimester, insulin needs continue to increase because of glucose needed by mom and baby. They may even double or quadruple, okay, those needs. After 36 weeks, it kind of levels off, and then once the woman delivers, everything should start to go back to normal. Okay, so this is just kind of a graphic that shows you first trimester, her insulin needs decrease. She doesn't need as much insulin. Then we get to the second trimester, and her insulin needs are going to increase because her insulin isn't as effective because it's trying to save glucose to go to the baby. But sometimes it becomes so ineffective that her glucose levels climb too high. And so right here in this star, about 28 weeks into the gestation, is when this happens. And her body is either going to figure out how to compensate for this and maintain her glucose levels and her insulin levels within norm while still providing for the baby, or it's not going to know how to compensate. And that's when the gestational diabetes develops, and her glucose levels continue to increase too excessively because her body hasn't figured out how to manage this new situation. Okay? So some key things that you need to know, and you need to remember these, okay? We've kind of already talked about this, is that maternal glucose will cross the placenta. That's how the developing fetus gets glucose to grow. Now, the interesting thing is mom's insulin does not cross the placenta, okay? So the infant does produce his or her own insulin, and you can see that it starts between 10 and 14 weeks. And so the infant, just like an adult or us, is going to secrete insulin in response to how much glucose comes over. So if mom is not managing her glucose levels well, or that 28 weeks and that gestational, that insulin antagonist system starts to create and it's not working, she can't compensate. So extra glucose is going to the baby because there's extra glucose floating around in her system. The baby is going to produce and secrete insulin in response to that extra glucose. Now, this is why we get big babies with diabetic moms. It is not really the extra glucose that makes the baby big. It is the extra insulin that the baby secretes in response to the extra glucose. Insulin in the developing fetus acts like a growth hormone. So the more insulin the baby secretes, it impacts their growth. And that's why we get those big babies, okay, those macrosomic babies, okay? The third key point to remember about diabetes during pregnancy is that these three hormones create that diabetogenic situation. They act against insulin just to make sure that there is glucose left over to go to the baby. Okay? Now, I mentioned before that mom is going to be prone to hyper and hypoglycemia during her pregnancy, especially if this is a woman who has not been diabetic before and she's not familiar with the changing glucose levels. So we need to teach her the symptoms so that she can recognize when they're happening and that she can intervene. Okay? Let's see. So we have the picture of the girl on the side shaking, hypoglycemia. So symptoms of hypoglycemia: hunger, irritability, weakness, dizziness. Their skin may become pale and clammy. They may have a headache. Okay. The hyperglycemia, become thirsty. They may also have a headache. They may have nausea and vomiting. They may experience some abdominal pain. They may have increased urination because their body is trying to flush out the system. It may cause an increase in breathing, respirations. And then also, if their glucose gets extreme, remember that can also cause that fruity breath, okay? And so when we're talking about hypoglycemia, a normal fasting blood sugar, depending on the resource that you look at, can be anywhere between 60 and maybe 100, 90, or 110, okay? It's close. So, but below 60, too low for an adult. We don't want to see glucose levels above 100, especially above 110. But when we're talking hyperglycemia and we start seeing these symptoms, we're going to see them get even higher, okay? But we want to make sure that a woman can recognize these changes by her symptoms, okay? All right. What can happen with our babies who are born of a mom who has either pre-gestational diabetes or gestational diabetes, who maybe did not manage their sugars well, is they actually can be at risk for respiratory distress. Okay? Now, this might be because, well, not might be, it is because the diabetes affects the development of their just whole physiologic, well, overall being, It affects their development, okay? So their lungs may be immature. But now remember, they may be born weighing an adequate weight or even being big for their weight, but they still may be immature physiologically, okay? So we always have to make sure that we're monitoring our babies of a diabetic mom for respiratory distress, okay? Because they may appear big and healthy, but they may not be fully developed on the inside. One thing that is very common with infants of gestational diabetes is that their blood sugars drop after birth. They experience hypoglycemia. And it's because they're used to getting glucose on a constant basis from mom. Okay? It's circulating through that placenta. It's constant. And so they've been used to this. Well, now they're born and that glucose supply is cut off. And so they now have to figure out pretty quickly, oh, I now have to make my own glucose. But remember, what do they produce on their own? They do produce insulin. So they have insulin circulating in their system and their glucose supply is cut off. And so sometimes it takes babies a while to figure this out. And so in the meantime, the insulin in their system uses up the glucose they have, and they don't produce enough fast enough. And so they can become hypoglycemic. And so when we're talking about an infant and hypoglycemia, we are talking about a glucose level less than 40, okay? This will usually demonstrate itself pretty quickly after birth. Sometimes within the first hour, definitely within the first couple hours after birth. And most hospitals, most nurseries have a standing order or policy that any infant that weighs more than 8.5 pounds or is born of a mother with gestational diabetes or pregestational diabetes, that they will have their blood glucose monitored for the first 24 hours after birth. Okay? Symptoms you will see in a newborn who has hypoglycemia, the most common one is tremors. You'll see their hands and their feet just kind of shake, and an increased respiratory rate. Their respiratory rate will be above 60 per minute. Sometimes if it becomes severe enough, then we can actually see apneic episodes, which then can also lead to cyanosis. Okay? So if we have not already checked their sugar, if we see signs of hypoglycemia, the first thing you have to do is you have to check their blood sugar. You have to know what it is. And then, of course, we are going to provide some type of glucose to them, and it's usually feeding them. Now, feeding them, this can be different depending on where you are. Some facilities and some physicians will just say, go ahead, just give them the bottle. So that way we know that they're getting a glucose supply. Some might see if it's a breastfeeding baby, then put the baby to breast. If they breastfed well, then that is sufficient. But some physicians will say, I don't care if they're breastfeeding or not, just give them a bottle so I know that they got some glucose, okay? We don't use glucose water. We give them formula or breast milk, okay? Because the glucose water doesn't have any other nutritional value to it, so we want to give them a full nutritional fluid. But the key is check glucose and feed them, whatever that feeding method has been determined. Okay, I'm not going to test you on whether to breastfeed or give them a bottle. The key is that you need to feed them, and then you're going to assess that glucose level usually about an hour after they eat. And you should see their glucose level go back up. Okay? All right. Gestational diabetes. We do not know who will develop gestational diabetes. We don't know whose body is going to be able to compensate to that diabetogenic situation that occurs. There are no predicting factors that we can use to see into the future. So, every woman should be tested for gestational diabetes during pregnancy. Now, let me clarify this. This is women who do not already have diabetes. If they already had diabetes and they're in that pre-gestational diabetic category, then we already know what's going on. Okay, this is a woman who was not diabetic and got pregnant. Every woman who was not diabetic and became pregnant should be tested for gestational diabetes. And this occurs between 24 and 28 weeks, around when that diabetogenic situation occurs. So there's two tests. There's the 1 hour and the 3 hour. Every woman should receive the 1 hour test. And so they're going to go to the lab. It's usually outpatient lab. They're going to drink a high glucose solution. And then 1 hour after drinking that, they're going to have their blood drawn for a glucose level. Okay? There's no pre-test requirements that they have to do. They don't have to fast. A positive result, which may be an indication of gestational diabetes, is if the result comes back greater than 130. Now, if the result comes back greater than 130, they should not be diagnosed with gestational diabetes based on that 1 hour test. This indicates that they need the 3 hour test. okay? So then we would make another appointment with them, and they would then once again go to the lab. It's done as an outpatient, but because it's a 3-hour, we want it to be much more accurate. They do have to fast overnight before going for this test. It's suggested that they shouldn't have any caffeine, or if they are a smoker, they shouldn't smoke before the test. Also, it can sometimes alter the results. Now for this test, they're actually going to have their blood drawn 4 times. Before drinking the solution, 1 hour after drinking the solution, 2 hours after drinking the solution, and 4 and 3 hours after drinking the solution. So they'll have their blood drawn 4 times. Before the drinking, 1 hour after, 2 hours after, and 3 hours after. And how are these results interpreted is right here. So over here you see if they had the 1 hour test done and it was less than 130, we're just going with 130. If it's less than 130, everything is fine. They just continue on with their regular prenatal care. If their 1 hour was greater than 130, they have to have a 3-hour glucose tolerance test. The OGTT is what this test is called, the oral glucose tolerance test. It's looking to see how does their body tolerate excessive levels of glucose. Okay? All right. In order for the test to be considered positive for gestational diabetes, 2 of these levels must be elevated. Okay? Not all 4 of them, just 2 of them. Okay? And so if 1 of them is elevated, then that's considered a negative. And they just will probably just continue on with their prenatal care. If 2 of these values are elevated, let's say at 1 hour, their glucose level was 190, and at 3 hours, their glucose level was 150. This one was within normal, this one was within normal. That's 2 values that were exceeded. So she would be considered positive for gestational diabetes. If 3 of them are elevated, she's definitely positive for gestational diabetes. And if 4 of them are, of course, definitely. Just 2 values increased can be used for a positive diagnosis of gestational diabetes. So if they are diabetic, how does this affect their prenatal care? Any woman who already has diabetes, so those pre-gestational diabetics, they should consider this when they are trying to get pregnant. They should make sure that they are having their appointments with their physician who monitors their diabetes. They should make sure that they have their diabetes in control, because it can help eliminate those risks or those complications such as a miscarriage or the anomalies to the infant's body systems during that first trimester. Whether they are pre-gestational diabetic, once they are diagnosed with a gestational diabetes, they are considered kind of maybe a high-risk pregnancy. So they're going to see their physician more often during the pregnancy. We had talked about the normal schedule of prenatal visits. Well, this will alter because of the diabetes. Okay, so especially during that 3rd trimester, when the baby is really going to do a lot of his or her growth that can be affected by her glucose levels and the infant's secreting insulin in response to that, they're going to be seen more often. A woman who is diagnosed with gestational diabetes should have a nutritional counseling session to go over foods that she should eat, she should avoid. Okay, how should she eat? What kind of schedule? We may have to teach her how to check her blood glucose levels with a finger stick. Okay, so some things to remember if you're doing that education is maybe warm her hands. It helps with the blood flow. Hold her hands down by her side for a little while to help get blood flow to those fingers. Okay, swab it with an alcohol swab. Let it dry. before piercing it with the lancet, okay? Depending on the severity of their diabetes, as I said before, she may be able to manage her glucose levels with diet, exercise. It may need oral oral diabetic meds, or it may even get to the point where she may need to go on insulin. And then we need to have a talk with her about what could happen if the baby grows excessively because of this glucose insulin situation that's going on. So we want to make sure that she's aware that at some point we may have to decide, you know what, you're about 36, 37 weeks, your baby's starting to get a little big, we're going to induce you, we're going to try to have you deliver early before the baby gets too big. If the baby's already to that point and the baby is a 9, 10, usually 10, 11 pounds, then that's when they may suggest, you know what, for the safety of you and your baby during a vaginal birth, let's do a cesarean birth, okay? Because that would be the less risk delivery method. Because of the risk to the infant, all of those prenatal testings that we talked about before, we're going to do those during this pregnancy. We're going to do ultrasounds to make sure we know the gestational age, the dates of the pregnancy. They may do them throughout the pregnancy just to assess the size of the fetus. The alpha-fetoprotein is going to be done for our pre-gestational diabetics to assess, did any neural tube defects develop? And then, of course, towards the end of the pregnancy, the second half of the pregnancy, if she's not able to manage her glucose levels well and we see big fluctuations that could affect the health of the infant, then we're going to teach her how to do fetal movement counts, those daily fetal movement counts. She's going to come in for non-stress tests. And remember, it's not going to be just one non-stress test. Once she comes in for one non-stress test, she's usually going to come in at least once, maybe twice a week. And then biophysical profile is also going to be done during that pregnancy. All right, so as I said before, she needs to be educated about diet. Her diet is going to have to change. Decreasing carbs, what other foods would be better for her to eat, what kind of diet schedule, exercise. There is exercise that we can do during pregnancy. If she's not already exercising on a regular basis, walking. Walking is a very effective exercise for a pregnant woman. It's very safe. As I said before, we may have to teach her how to monitor her blood glucose at home with the little glucometers. How often is she going to have to do that? This is individualized according to each woman's situation and their glucose levels. So I'm not going to tell you that she's going to have to do it daily or twice a day or every other day. That varies, okay? As I said before, fasting, depending on the resource you look at, maybe 60 to 100 would be considered a normal. Some books might go up to 110. Some books might say 60 to 90, okay? For right now, for our textbook, this is what we're going to use. If she were to check her sugar 1 hour after eating, this is where we would want to see her sugars. 2 hours after eating, this is what we would want to see. If they are consistently higher than this, if her doctor has her assessing her glucose like this, then they may have to make some changes as far as medications, okay? And so she would have to keep a log of her glucose levels. And then, of course, because the pregnant woman is at risk for hypoglycemia, we want to make sure that she's aware of those symptoms. And we want to make sure that she knows what kinds of foods she should carry with her that she could take that will give her a quick glucose kind of rush or source to help bring up those sugar levels. Hard candy, you know, she can carry those. She can put those in her mouth. She can suck on those as they dissolve. They're going to help increase her glucose level. Of course, we have glucose tablets that you can buy at any drugstore that are very effective. She would take those, she would chew on those. Orange juice. Drink orange juice, a cup of orange juice. Drink a regular pop is another way to quickly increase her glucose levels. Okay, so we'd want to educate her about maybe carrying. It's not so easy to carry, maybe pop or juice with you, but she can buy one of these little tubes of glucose tablets or some hard candies and keep those in her purse. Okay, and so that is the lecture on high-risk pregnancy. That's it. Bye.